Thank you, and good morning, everybody. And a big Calgary howdy. If you haven't been told howdy before, you're going to hear that a lot today. So, big howdy, and welcome to the first leadership session of the conference entitled Digital Health Landscape Change Agent Perspectives. My name is Gary Laxdal, and I'll be the patient moderator for this exciting session on digital health change landscapes. First of all, let me tell you just how thrilled I am to be a patient advisor here today with Canada Health Infoway. For those that don't know, we have a big table down here with our patient partners, and it's great to have such a patient-inclusive conference, as Lynn said earlier, so again, thank you very, very much. I'm from Calgary, and I was a technology business owner here in Western Canada for over 25 years. And I retired about 4 years ago, and then a year later, so 2.5 years ago, I was diagnosed with rectal cancer. And as you can imagine, this is not what you want to hear when you're an active 53-year-old Calgarian, and just kind of threw me and our whole family for a loop. So, with that in mind, when I was told that I was going to have major surgery, it was called APR, abdominal perineal resection, and I went through intensive radiation therapy and chemotherapy, and then I was introduced by our fantastic people here. I don't know if we have anybody from Tom Baker Cancer Center here or the Foothills Medical Center, but they introduced me to a new procedure called Enhanced Recovery After Surgery, or ERAS. You've probably heard of this, it's worldwide. And with that, they introduced me to new online tools that I could better prepare myself for surgery. So I knew that the surgeons, they were all getting ready, they were all trained. Well, I wanted to do my part, and I wanted to train myself and just better prepare myself for my upcoming surgery. So like a madman, I researched as much as I could into ERAS, into my disease, and how to ultimately beat cancer. So, by using all available digital tools, I'm sure that this helped me get through a very challenging time, and it also helped me, come to terms with my disease and, how I can best fight this and move forward. And, it turned into a very successful outcome, and I truly am an unstoppable survivor. Just to give you an example, after my APR surgery, I was golfing within 2 months, and I golf a lot. My wife and I golf well over 100 rounds a year, so it was nice to get back to the new normal, as I call it. So now I volunteer here in Calgary and Alberta with Alberta Health Services, and I sit on what is called the Surgical Strategic Clinical Network, or SCN. Within AHS, there's 15 SCNs. And I'm also the co-chair of the Patient Engagement Reference Group with the same network as well. And one of the exciting things we're working on right now with our surgery SCN is we're co-designing an app for colorectal patients, and that gives them new ERAS information. I sure wish I could have had this a couple years ago. Just again, when you're a patient, you're always searching for new things and searching for help. And so this is what we're co-designing. It's a new app, actually with a company we met here at last year's partnership conference called Seamless MD. So, and by giving our patients all our digital tools, this allows them to partner together with their medical teams and co-create better outcomes. Last year, one of the things that resonated with me at the conference is we heard patient engagement is a blockbuster drug of the 21st century. Well, it truly is, and I'm living proof that by having an active wellness campaign with your support teams will ensure you with digital health tools for better outcomes. So for today's session, each of our panelists up here will first share their experience as change agents in the digital landscape here in Canada, and following their presentations, we will open up the floor to questions. So please don't be shy. So we want lots of questions, we've got an exciting panel. So our panelists include, we start off with Nancy Lefebvre. Nancy is the Chief Clinical Executive and Senior Vice President of St. Elizabeth Healthcare. St. Eliz, as they're affectionately known, delivers a wide range of home health care services across Canada provided by registered nurses, personal support workers, community health workers, and rehab therapists. And Nancy is also responsible for sharing and advancing St. Elizabeth's shared value strategy and positioning the organization as a leader in social innovation and impact. Next, we'll have Bruce Winston. Bruce is an Albertan, and he's a community pharmacist and founder and president of Sandstone Pharmacies. Bruce operates over 19 pharmacies here in central and southern Alberta, and he also serves as a member of the University of Alberta's Faculty of Pharmacy and also on the Dean's Advisory Council. Our third panelist is Dr. Trixie Gregoire. Trixie is originally from rural New Brunswick, and she is now a family physician practicing in Halifax, Nova Scotia. Dr. Gregoire has been using Nova Scotia's personal health records for almost 5 years as a way of communicating and sharing information with her patients. And it's a real blessing to have all three panelists up here. To set the stage, we'll first hear from Chad Lever. Chad is the Director of Applied Research at Canada Health Infoway. And Chad will be giving us a brief national update on the digital health landscape and adoption rates in Canada. Chad?
Thank you. Thanks, Gary. Thanks so much. And this will be somewhat of a lightning round to set the stage, and then I'll turn it over to our esteemed panelists. So 10 years ago, when I was using my flip phone and smartphones were just coming up on the scene, adoption of EMRs by primary care physicians in Canada was at 24% and 28% among specialist physicians. Today, like many of you, I have the requisite 2 smartphones and 1 mobile health tracking device. And today, 79% of specialists and 85% of primary care physicians report using an EMR to enter and retrieve patient notes. An optimized use of EMRs by primary care physicians is currently modest. Yet, there is no denying that the acceleration of digital health, particularly in the primary care setting, has been remarkable. But let's broaden our view and turn to the adoption of electronic records across all healthcare settings by Canadian nurses. In 2017, the National Nurses Survey captured information on the use of electronic records across both community and hospital-based care settings. In primary care, nurses report the highest use of electronic records instead of paper to support patient care at 78%. And paper-based systems continue to preside in about over 20% of community health centers, nursing homes, and public health, and well over a third in home care settings across Canada. In hospital-based care settings, we're essentially seeing about 10 to 20% of nurses using only electronic records instead of paper, with the exclusion of nurses practicing in the emergency department, where just 4% report using electronic systems only. A fair proportion of nurses practicing in non-academic or complex continuing care hospitals are paper-based only, while paper record-keeping systems are only in 4% of outpatient care settings. Overall, about 3/4 of nurses practicing in Canada that are providing direct patient care are accessing multiple electronic systems as well as paper records to support a patient encounter, and 56% of nurses report that they document an encounter using multiple systems. Nurses are also accessing regional connected patient care information systems like the EHR, and about a third have reported that they have access to single sign-on, but the majority do require multiple logins across multiple systems. Despite this complexity, it's abundantly clear that that Canadian nurses are largely working in digital environments to varying degrees, and the paradox there is the more that functionalities they use, the more likely they are to say that they're more productive and the quality of care they provide is higher. By all means, these are superheroes in the digital health landscape. When it comes to community pharmacy, the integration of technology is well advanced and use among practitioners is highly optimized. Virtually all community pharmacists in Canada report the use of electronic warnings for adverse drug events, interactions, clinical decision support tools, and electronic reminders for patient care. And most access electronic lists of all medications through provincial drug information systems where available, and are able to do so via an integrated sign-on. Anyway, the use of digital tools are undoubtedly in play, But before I turn it over to the panel, but first let me tell you what Canadians think. The latest Commonwealth Fund survey of adults across Canada looked at 11 countries and suggests that because of the issues with timely access to communication with primary care services, Canadians continue to access emergency departments for care. And Canada, in fact, ranks lowest among the 11 countries on receiving same-day answer by phone when calling their office during office hours about a healthcare issue or concern, and the lowest on having access to personal health record information. When asked, most Canadians think the healthcare system needs fundamental change to work better. In Infoway's 2016 surveys, Canadians were clear on what they were interested in emailing their physician, having access to their records, as well as being able to renew prescriptions online. And in terms of availability, in 2016, what Canadians say they can access, 22% say they can request a prescription renewal, 20% can access their records, and 14% say they are able to email their care provider, with really modest utilization across all three functionalities. So these results are just a glimpse at the current Canadian landscape. And with that, I'd like to turn it over to Nancy Lefebvre.
Thank you, and good morning. It's a pleasure to be here this morning. And as I was flying in and heard the comments earlier about the big blue skies, it reminded me of a song. I'm Alberta born and raised, but transplanted to Ontario, but it reminded me of a song that my mother wrote, and her opening line is "Wide blue skies, sun shining bright, in memories I roam." And as I was flying in, it just really struck me how true that is for me and how nice it is to be back here in Calgary. But anyways, it's nice to be here to be able to share some thoughts on the digital healthcare landscape. And more specifically, I'm really interested in hearing the patients' and clients' voice and perspective around what they see as important and how they're going to help us lead the way. So to begin with, let me tell you a little bit about St. Elizabeth so that it gives you some context in terms of some of the things I'm going to talk about. So St. Elizabeth is a not-for-profit charitable Canadian organization established in 1908. We are started with 4 nurses in the downtown core of metropolitan Toronto and have evolved considerably since that time and are now recognized as one of Canada's largest social enterprises. We have 9,000 staff across the country made up of nurses, healthcare aides, community health workers, and all 5 allied health disciplines. And they provide together collectively 20,000 visits a day. And in the last 10 years, we've provided over 50 million visits. And so I tell you that because I think it gives us a very unique perspective, both from the scope and scale of the work that we do, but also the fact that we are invited into people's homes and their lives at the best of times and sometimes at the worst of times too. We see people in their homes and their communities. We see them in their long-term care facility residential environments. And we see them on the streets. We see them in parks, we see them on the streets, and we see them under bridges throughout the entire country. And this experience gives us, I think, a unique perspective on how people and their daily lives intersect with healthcare and how they utilize their resources, their communities, and their networks to actually engage with healthcare. And we hear time and time again that people want care where they are at. And they want health care that seamlessly fits into their lives versus trying to figure out how to fit themselves into the healthcare system's lives. However, I would suggest that in order to do this successfully, we need to completely rethink and restructure the way care is delivered, the way care is organized, and the way care is funded. And certainly at the heart of that, we need to look at how we can use digital health technology not as an end, but a means to an end and as an enabler to better health care. So at St. Elizabeth, just to give you some examples of some things that we've been doing using technology to support patient care and education and for a number of years. And I was laughing because our first innovative foray into technology was the use of portable fax machines, if fax machines could really be portable. Our staff had a heck of a time finding homes in the downtown core of Toronto with 3-prong plug-ins to start with. So those fax machines very quickly became desk machines, but the whole point of them was really to enable access to patient information and records at the point of care in the home, and also to be able to access information and education that could be shared with patients and their families in order to support their care and to inform them about healthcare choices. So we have certainly continued our evolution with the use of technology since the start of the fax machines, and have gone beyond that, but I believe that we're really only at the tip of the iceberg. I think that if we think about home as the hub for healthcare, and we begin with people in their homes with their networks and the resources, and think about how we can use digital health to enable care from there, I think we will have the opportunity to unleash incredible potential in the digital healthcare space. So in terms of some transformative projects that we've been working on, typically in using technology, a lot of them have been through our work with hospital partners and also patients as partners. And we've been able to leverage several forms of electronic means or health technologies, including things such as the integrated record of health, which actually belongs to the individual or the patient. It's located on their laptop, and that it's accessed by all the healthcare providers, and in fact they're coming back for return appointments, bringing their laptop and their electronic record back to the hospital for visits to share with the healthcare providers the information. We've used technology to create online resources and educational tools. We've used technology for remote monitoring and for virtual visits. And we've also used really simple technology called the telephone for access to 24-hour clinical support. And it's very interesting in some of our transitional care programs, when we evaluate them, the biggest feedback we get is that the number one source of contact and connection with healthcare providers, giving people comfort in their homes so that they have confidence to care for themselves and they know how to care for themselves, is that access by a telephone where they get an immediate response and they know the person that they're talking to. So sometimes it doesn't really have to be that complicated. In terms of the results from these programs that we've been involved with, we found that we've been actually able to help avoid unnecessary hospitalization. We've been able to reduce length of stay in hospitals. We've been able to reduce emergency room visits. And with our one program in particular, putting patients at the heart program, which we're partnered with Trillium Healthcare in Ontario, we've actually been able to reduce the length of hospital stay by 2 days, and we've had a 38% reduction in readmission to the hospital. So some good stats that demonstrate that through partnerships, as Andrew was talking about, through partnerships, but as well as through engaging patients and utilizing technology as an enabler, there can be different strides made. So while I think that technology has been quick to change and evolve, I don't think that we can say the same for the uptake for health care clinicians. And it's interesting, Chad, in terms of some of the results, we met yesterday to go over the nursing survey, and we have come a way since 2014 to 2017, but we have a big gap to go where 50% of people are not using technology to be enabling their care. So I think that we need things such as different types of funding models to follow the technology for the delivery of virtual care, access, information, education, and consultation. And we need more flexible models of care that are outcome-driven in order to take advantage of the technologies both for ourselves as clinicians, but more importantly for patients. So thinking about some of the demonstration projects that exist today, we have done a great job of piloting innovations. And one of the questions we were asked was to speak to was, what are the things that are slowing us down in terms of moving forward with innovations, utilizing technology? And I think there are twofold. One, I think the first one is that often new technologies and models of service that are bundled together are often introduced without an accompanying business case. So as a result, the longevity or the sustainability when we move to spread and scale doesn't exist because there's no accompanying business model to make it feasibly sustainable or financially viable. That's one thing. I think the second thing is that with the traditional approaches we have today to procurement of technology, they don't take into consideration that perhaps the technology that we are looking for is yet to be developed and is not prescriptive, and that it needs to be co-designed with patients and clinicians together to get at the real solution in order to be able to have large-scale spread. So those are two things that I think together as healthcare leaders we need to influence. We need to influence things at a policy level to be sure that we're changing the policy, we're changing funding, and that we're moving towards that healthcare outcome-driven environment where patients are at the center of it. The last question we were asked to respond to today was, or is, what digital health services for patients are the most important for advancing patient engagement and access to care? So my response to that is those digital health services that the patient deems most important and most valuable for their own care. And at St. Elizabeth, we have a saying that's all about the starting point and how important it is to determine where you're starting, because where you start will impact where you end up. And so if we're looking at revolutionizing the healthcare system and we think of people and patients in beds and hospital gowns, we're going to design one kind of system. If we look at patients and people in their homes, surrounded with their own resources, their own technology tools, and their own network, we're going to design a system that looks very different. So I think that the most important thing for us to think about as healthcare providers is to stay focused on the patient and what they value most, and to understand technology as a tool and enabler, which is not the prize, because the prize of the day is really about creating amazing experience and a good healthcare outcomes and journey for patients and their families. I think co-designing, as we heard about today, or co-discovering, is going to be at the heart of the way that we develop technology in the future. And I think when we look to the future, we will be figuring out how does healthcare intersect with the daily lives of people in their homes and their environments versus the other way around. And I think I'll stop there and pass it over to my colleague.
Thanks, I appreciate that. When I entered pharmacy practice, there were no computers in the pharmacy. We used a card filing system to keep track of patient prescriptions. And if we didn't recognize the person on the other side of the counter standing in front of us, we'd file it under a miscellaneous card. For example, all patients with the last name starting with the letter M were filed together. That's not great for record retrieval, for sure. But at that time, now that I think back of it, filling a prescription was more of a transaction. You give me the prescription, I give you the medication, and a little bit of advice on how to take it. So today, I'm going to talk to you from my perspective of current pharmacy practice in Alberta, with a reminder that the pharmacist scope of practice in Alberta is the broadest in North America. And I'd like really, I take the opportunity all the time to thank the Alberta College of Pharmacists, the Alberta Pharmacists Association, and the government of Alberta for working together, allowing us to lead the way. My role as a leader in my organization has evolved, and I've become a change agent for my professional team. 30-some years out of university, and all I see when I walk into my pharmacies is opportunity. Sometimes I'm the only one there that can see around the challenges to the opportunities. Especially with the younger practitioners, sometimes technology gets in the way because that telephone, that smartphone is always at the end of their hand. And they get tired of hearing me say, just take care of the person on the other side of the counter. That's usually followed up by my reminding them that the person that's standing on the other side of the counter has come in because they need something. And oftentimes they're not feeling 100%. Our job really is to focus on what their pressing need is, whether it's extending a prescription, advice on over-the-counter medication. Sometimes they want us to assess an injury to some part of their body, or maybe they just want some reassurance on something that they've just discovered in a Google search. In this way, community pharmacists today are taking on a few of the traditional roles of the primary care physicians, in that the questions we're receiving are now anywhere from soup to nuts, not just about medications. And we're expected to perform a quick patient assessment and then refer on to another healthcare professional when the query goes beyond our scope. However, our patients don't need an appointment to see us. They simply walk up to the counter and there we are. In no way am I trying to imply that pharmacists are able to replace primary care docs. Far from it. I don't want the backhand from Trixie either. So I'm only saying that pharmacists are trained today to be able to do far more for patients than just dispense medications. And technology is a tool for us in our effort to provide an enhanced level of care. One of the most frequent questions that I'm hearing right now when I'm in my industry is if I'm worried about giant e-commerce companies like Amazon getting into pharmacy. It's hard to imagine a company being more connected than Amazon. For sure, they'll create enormous hurdles for bricks and mortar pharmacies, just like when the retail giant Walmart entered Canada. But I'm quite sure that companies like Amazon can figure out a way to dispense medications robotically, probably at a lower cost than I can at my pharmacy. But honestly, the way that pharmacy practice has evolved, away from that strictly transactional basis, gives me so much encouragement about the future for my profession. Pharmacy is just touching the surface in what can be achieved professionally for our patients. Almost every survey shows that we're viewed by our patients as the most accessible healthcare professionals. I was asked to pick one digital advance that has transformed clinical pharmacy practice more than anything else. Access to Netcare in Alberta has enabled pharmacists, especially prescribing pharmacists here, to affect health outcomes for their patients more than any other recent technology that I can think of. Netcare contains we'll call it mostly accurate, electronic medication record, historical labs, and diagnostic information. An example of how we would use Netcare with our patients is this. Patients, they can't always remember if they've taken a medication previously, and as much as I'd like to think that my patients would never go to another pharmacy, the reality is that sometimes they do. A basic check on Netcare provides us with this information. And if we find that the medication is new, we may choose to offer a trial prescription for a short duration and then phone the patient to see what their experience has been. Are they experiencing any side effects? Have they seen any benefit yet? All too often, the expected side effects, which may be transient in nature, they show up before any of the expected benefit. And in these cases, just like with smoking cessation, a pharmacist reaching out and encouraging the patient to continue with their therapy and to remind them that what they're feeling is expected and normal and will get better with time is all that's necessary to keep that patient on course. If I was feeling crappy after starting a new therapy for a chronic condition, I'd probably quit taking my medication too, and that's what happens every day. But I'm trying to get my pharmacists to use technology to help them to schedule calls to their patient, to document those calls, and to encourage them to stick with that medication, even if this requires a weekly touch point until their patient is stable. It's hard for me to imagine why government considers limiting the number of times it'll pay a pharmacist to follow up with their patient as an effective cost containment strategy, when the cost to the system for non-adherence is so demonstrably high. So if Netcare access has been a positive change for practice, what are a couple of examples of things that have been slower to change? Well, the first one that came to mind was, I find that we're creating more volume of paper than we ever have before. While it's hard for me to fathom the way that we used to, manually record a prescription record, I believe the advancement of pharmacy software management programs, they've been slow to evolve, and paperless workflow is not quite paperless yet. It's not necessarily the fault of the various software vendors. Think of the challenges they face in Canada. Each provincial government has its own set of drug information system requirements. Each provincial college varies slightly in their requirements. Each third-party insurance carrier treats claims slightly differently. And the scope of practice for pharmacists varies widely from province to province. And what's the result? Well, the software vendors, they have to create multiple versions of upgrades, even for the smallest of changes. Another area that's slow to change is that we're currently stuck, just like Nancy said, with fax technology. When I was thinking about it, I'm quite sure that student pharmacists and physicians entering practice sites for the first time probably go home and they do a search on YouTube for an instruction on how to work a fax machine. Put the original face down, dial the receiver's number, wait for that handshake signal, and it's amazing that we're stuck there. If I could create a priority list for areas in digital health that I'd focus on to help me deliver better patient care, I'd include e-prescribing. improving pharmacy management software services that will make it easier to synchronize medication refills for patients, create and maintain care plans, and trigger patient follow-ups by the pharmacist. These initiatives will help reduce the huge costs of healthcare in Canada. An estimated $7 billion each year is spent treating people in hospital for complications resulting from medication non-adherence. 25% of written prescriptions are never filled. 50% of Canadians with chronic diseases are non-adherent on their medications, and 50% of prescriptions that are filled the first time are not dispensed when the first renewal date is due. 50%. One of my pharmacy colleagues is quick to point out that a medication is guaranteed not to work if a patient doesn't take it. I'm reminded of the wisecrack in the airline industry, where they ask, where is the most expensive place to park a plane? And the answer is, in the air. If we were to take that truism into the healthcare industry, well, the question would be, where is the most expensive place to treat a patient? And the answer is obvious, it's in the hospital. If I were in front of provincial health ministers today, I'd be urging them to reinvest some of their savings that'll be realized with less hospital admissions into two areas. First, create a stable funding model for e-prescribing. Pharmacy alone cannot be counted on to underwrite the full cost of e-prescribing in the future. All parties that access the push or pull system should participate in the costs. And second, once pharmacists receive the e-prescription, then for goodness sake, fund the model that encourages pharmacists to work with their patients to take their medication as prescribed, and allow the pharmacist to follow up with their patient as often as clinically necessary to reach their medication or their health outcome goal. And if the patient cannot tolerate the medication, then the pharmacist should attempt to find an alternative, a suitable alternative therapy, or refer the patient back to the original prescriber. When I look at existing digital services, are there a few that we could leverage to have the most impact on advancing patient care? Absolutely. Why can't we integrate the electronic health records from various disciplines, including pharmacy care plans, physician care plans, plans from chiropractors, physiotherapists, dietitians, et cetera? That would allow us to align our goals of therapy with those of the patient, and it would be so much less confusing for our patients, and it would be so much less expensive to the system than having us all start from scratch. And next, why can't we figure out a better way to deal with hospital discharge orders? Rarely do we receive a hospital discharge order that we don't have questions about. For example, often we don't fully understand the status of a patient's earlier medications and conditions. And the discharge order just kind of adds confusion in what we communicate with our patients. The patient goes home, restarts an older medication that had been discontinued, and back in the hospital on a readmission. And finally, and I think it'll be a constant theme, why can't we increase access to electronic health records to the patients themselves? It is their information and should be accessible and portable for them wherever they are and in whatever circumstance they find themselves in. They should be able to contribute information to their own record. We can't just keep telling ourselves that the patient is at the center of care without providing them with the tools to be able to access and contribute to their own health record. Thank you.
Thank you, Bruce. I really am just going to share some of my experiences with. Oh my, it's pointing up. I don't know. Can you hear me okay now? Okay. What about now? Yes? No? Can you guys hear me?
Here.
He's bringing them.
Thank you.
Thank you. Well, I feel like I should sing holding a mic like this, but you don't want me to sing. I really just want to share some experiences using what we call our PHR, so Patient Health Record. We've been using it for about 5 years now. The first few years it was in a pilot project, and now it is available to all doctors in Nova Scotia. And it's really changed the way of practice. So it is through Relay Health, and now Nova Scotia calls it My Health NS, and it is available to all patients in Nova Scotia whose doctors use the program. So not all doctors are using it. So it really changed my practice in the main way by communication. So I can definitely communicate with my patients in different ways and in easier ways. So the way I've kind of broken it down is it's more accurate, it's more efficient, it's easier, it's flexible, and it allows me to communicate with my patients in a way that I've never been able to communicate before, and that would be in group messaging. So I talk about broadcast messaging, so I can send a note to all my patients at the same time, which really makes a difference. It is definitely more accurate. I'm sending the right information to the right person. I know lots of times we call patients and we get their answering machine and you don't know who's listening, you can't leave a message, you play phone tag most of the day, so it does help in that regard. And also there is a little checkbox that I can check off if I really need the patient, if I really need to know if the patient has gotten the information, so I can set it up whatever way I'd like to. So if I need to know in 1 day, 4 days, if the patient has read my message to them, I will get an alert that they haven't read it, which is very helpful because there are times where I need to know if the patient has got my message so I know they can arrange follow-up. So lots of times I leave messages with the teenage son, just even to call the office, and I never know if that message goes anywhere. So at least I know. Not that I'm picking on the teenage sons, but that's just an example. And also it's documented. So whatever I say to the patient is written down. So there's no error in terms of them calling the front desk and saying I said one thing when I said something else. So everything is documented in terms of what I say to them and what they say to me. It's more efficient. The thing I was actually surprised the most about using the system is that I can, and in a little amount of time, I can help a person on a day that they're struggling. So for an example, I can write a 1-line sentence to a patient who's waiting for biopsy reports and say, just hang in there, I know it's a hard to wait, and or if they've had surgery and I say, I hope healing is going well, and multiple times patients have said to me it meant a lot for me to hear this information, and it's amazing how I can do things very quickly in a short amount of time, and it can make a difference on their end. And I think even we get the specialist reports back, so I may just say, here's the report from the cardiologist. I may say nothing more, and the patient knows I got the report and I read it, and I'm sending it to them, and that makes a difference to them. It is easier in a lot of circumstances. I have a few patients that are deaf who I actually communicate easier with the system. I have a patient who has a stroke who can't communicate quickly, but when she takes her time and writes back and forth, she finds it very helpful. And just patients who are far away in other time zones. I had a patient a couple years ago who had a biopsy. I was writing her back and forth from Africa, and it's been helpful for that sense. The other way it's been very helpful is in a very specific population, which would be patients who have caregivers who come to their appointments and who help them out, especially patients who have dementia, because sometimes you can't say the things you need to say about the patient in front of the patient. You know, they're in denial, or it might upset them to hear some of the things their kids want to tell me about them. And this way they can send me information before or after the appointment, and it has been helpful. In the past, they've called ahead and said, can you please ask the doctor to bring me in first? But some of these people aren't my patients, only their parents are my patients, so it can get a little tricky sometimes. It's definitely flexible. I don't have a lot of time in the day to do my paperwork. I'm busy seeing patients, so I can do it early in the morning, late at night. I can't be calling people at 6 o'clock in the morning. They're probably still in bed, so it has been helpful that way. And in large-scale messaging, Public Health has asked us to send information on Lyme disease a couple months ago, and very easily I could send all this information to my patients. Before I go on vacation in the summer, I always send out a message saying these are the weeks I'm not available, and it's helpful for the patients who have medications that only I can prescribe. They don't get stuck not knowing I wasn't going to be available. The other thing which has been very helpful is that patients have access to their records. They have their lab results, they have their x-rays, they have most of the reports that when they have seen specialists. So they can look at them, they can compare them, they feel more in control of their own health. And I hear them coming in saying, you know, I checked my sugar or I checked my cholesterol and it was worse than last time or better than last time. So they do feel they're more responsible for some of their actions in terms of monitoring their health. The other thing which is helpful is patients are very good proofreaders. So they're better than anyone you could pay to proofread for mistakes. They read their reports very carefully, better than me most of the time. I'm skimming them, I'm busy, but they always are quick to point out if there's any mistakes. Now, some of these mistakes aren't important clinically, but there have been times where it has made a huge difference that something has been written in error, and they are quick to see this, and it's helpful. And I think that they do have access to their blood results and x-rays in a pretty timely fashion. You can change the way they receive the results. I manually send them all to them because I usually send a quick note, but you can just release them automatically, and there's a little debate about what time frame is reasonable. I think one of the things that's been the slowest to change is I'm surprised that a lot of the doctors aren't using this system, especially the doctors who I work with who know I've been using it for years. And I feel like it's a very helpful tool. So as of last month, there was about 225 family doctors, I guess, in Nova Scotia who've been using it, and about 11,000 patients. So if you do the math, that's only about 50 patients per doctor. So a lot of these doctors probably aren't using it to its full potential. They've probably signed up but aren't really using it on a regular basis. I would say about 70% of my patients are on the system, and I think that's when it becomes helpful, is when the majority of your patients are using it. If you're just starting out, it's hard to see the benefits because you don't have the ability to reach a lot of your patients. And I think one of the reasons, well, two of the reasons why this is happening is there are no fee codes for doctors for these particular types of non-face-to-face visits. So all this stuff I do on my free time, I can't, it's extra work for me, and you get not a lot of benefit back from it in terms of taking more of your day to do things. So I think I could efficiently see more patients and give them the information they need, and if I could build it into my schedule. So I think that would be helpful. Right now there's a huge crisis with needing new family doctors in Nova Scotia, so I think they're limited of who they can get as a doctor, so they need to use our time more efficiently and allow us to see more people. So in our pilot project, we did look at what we called e-visits. So they were visits where you didn't have to see the patient in person, and about a quarter of the visits, especially follow-up visits, could have been an e-visit, so it could have saved the person time from coming into the office. And certainly I have patients who live a couple hours away, 3 hours away, they've moved and they can't find a new family doctor, so for them to come in just for me to tell them their blood work was normal is a big waste of their time and my time. The other thing is probably integration. So it's overwhelming to think you have to do something twice when it's already hard enough to do it once. So if you have to look at the lab results and sign them off in your EMR and then do it again in the PHR, that's extra work. And I think we're charting in more than one system, so you have to kind of copy and paste, and so just the extra work is a big factor as well. So the things I think of in terms of what's important for the future of patient digital health would be the two of the main things I already talked about. Communication. I think communications between the doctors and the patients, or at least the patients and the front staff or the nurses, because I know a lot of doctors are really worried about their patients being able to contact them directly, is important. And I think patients have to have access to their results in a timely manner so they can see these results and it is helpful to them. The only other thing I would comment is whatever systems the doctors are using to deliver this to the patients, I think have to be quite flexible, because in the meetings I've had with lots of other doctors, even just family doctors, I realize we all work very differently and have our own way of communicating with patients, so I think it needs to be able to be tailored to how we work and what we need in terms of communicating with the patients. Thank you.
Thank you, Dr. Gregoire. We'd now like to open up the floor for questions. Please raise your hand if you do have questions. People will come around with some microphones, I believe, and we'll ask questions. I'd like to ask the panel a question to start, if you don't mind. So I need you to look into your crystal ball, and it's the year 2027. And Nancy, maybe you can start us off. How has your business changed in the delivery of healthcare as a result of digital health tools?
Well, I think today, and we heard a comment earlier, is that patients' expectations about how fast we incorporate healthcare technologies into healthcare exceeds the pace of how it's happening. And I would hope that in 2027 we flip that around, and in fact we're incorporating technology into healthcare practices at a pace that it exceeds consumers' wildest imaginations. I think that also that we're co-designing services more from that standpoint, and that more services are developed utilizing technology that we use in our everyday life.
Bruce? Well, I think that pharmacy has been one of the healthcare professions that's pretty connected in terms of what we're doing. But what I would see out in the future, or what I'd hope I'd see out in the future for sure, is a better way for patients to participate. That shared EMR would be fantastic. But I actually see pharmacy taking a larger role in point-of-care testing for sure. And I'd love to be able to see pharmacy play a bigger role in pharmacogenomics and some of the DNA testing. And if we're the medication experts, then we better start to figure out which medication is right for the patient.
Good.
Thanks, Bruce. Trixie?
So I guess I'd have to think about what doesn't work now and how I hope it's fixed in 10 years. And I think the two main things for me would be a hole in the information. So I know I have the information for my patients in my office, but when they're admitted to the hospital, it's like a black hole, and I don't really have access to that information easily. I will get a summary in the discharge summary, but it's not always including everything, and sometimes I don't get it I have follow-up with the patient, and I don't have the information I need to do the follow-up. And the other thing I really hope is better in 10 years is the way we make referrals. And I don't know if it's like this in other provinces, but when I refer a patient to a specialist, I just cross my fingers and hope it all goes well. Like, there's no real way to track that, and I think it would be important to have a system where we know the referral is received, we know the doctor will see the patient. Just last week, I had a referral note come back from a urologist a year after I made the referral saying, I can't see this patient. Well, that would have been nice to know a year ago, so the patient's been waiting a year for nothing. And just to know that the wait time, I think, is very important, because we have really long wait times for specialists in Nova Scotia, so I think the patient can mentally prepare. If they know it's a 2-year wait or a 6-month wait, if they think they're going to be seen next week, they're going to be really disappointed. So I think that we need to have that information available.
Thank you.